KRAS mutant non-small cell lung cancers represent a significant portion of all these tumors. And so far, there was no drug which would be targeting this specific mutation. And as now there are emerging new treatments which are targeting this driving mutation, it's essential to identify the patients who are bearing this mutation because they can benefit from the targeted treatment. So like in the past, we were struggling with identification of patients with EGFR mutation, or later on with ALK rearrangement or ROS1 rearrangement. Now we are starting to detect KRAS mutations. It's the same process, it's the same methodology in fact, like with the EGFR. The only difference is that before we were detecting just one marker. Now we have to detect all of these markers, and this requires, let's say, a more sophisticated approach than in the past. We know that lung cancer or non-small cell lung cancer is not one single disease. In fact, it's a basket of tumors with different mutations, and some of them are potentially druggable. And to identify all these mutations requires a sophisticated approach. It means we have to detect in very small specimens of tissue, which have, let's say, 1 or 2 millimeters in diameter, many different genomic alterations. And this requires approach when we test all these mutations simultaneously. So the only solution which is first economically sustainable, and second potentially applicable with this limited amount of tissue is so-called NGS, or next generation sequencing, also called massive parallel sequencing, when we detect different genomic alterations during the same test. Well, if we think a little bit out of the box, KRAS is a marker which has been detected for maybe 10 years already, but not in lung cancer, but in colorectal cancer, where it's a negative predictive factor for treatment of with anti-EGFR directed antibodies like panitumumab or cetuximab. In lung cancer, so far, it was not detected. So it's an emerging marker which has to be tested as one of the new markers together with other ones like HER2 or BRAF, RET, FGFR, and others. Basically, we are detecting some of the markers at the DNA level. This is, for example, EGFR, KRAS. And some of them we are detecting at the RNA level, like different gene fusions, ALK, ROS, FGFR, RET. So these are two different approaches. In, let's say, future years, it will be most probably possible to detect everything within one test. At this moment, we are still struggling how to implement all the tests into one single method, which is, let's say, challenging, but doable. I strongly believe that KRAS will be included into the standard set of detective driver mutations, and it will be a routine in every newly diagnosed lung cancer patient with advanced disease. It means with metastatic non-small cell lung cancer. So because the treatment is targeted directly on these genomic alterations, the patients must be appropriately identified. It means the one-size-fits-all treatment approach is over, and now we have to subclassify the whole group of non-small cell lung cancer into individual molecular categories, and each of them will require a different treatment approach. I think that I might add that the current development illustrates very well that pathologists should be an integral member of the multidisciplinary team, and I see the future in organization of molecular tumor boards, where the more and more sophisticated or complex information which we get from this genetic testing will need a very thorough and qualified interpretation, so that the clinicians, oncologists, will be able to decide based on this for best treatment for each individual patient.